Good morning, this is Brenda Williams, nursing care manager, pre-hook cath lab, also chest pain coordinator and heart rhythm analysis manager. I'm going to go ahead and start with the STEMA report for August 11th. On this particular EMS run, it started at 1:59. They received a call that a 68-year-old male with a complaint of chest pain. I can take this off. Seems so silly to wear it when there's nobody here. You guys are 6 feet apart. By 2:07, they arrived to the patient. The patient was standing at the end of the driveway. Skin was pale and dry. Respirations were adequate, non-labored. Radial pulse was strong. Patient states he awoke from sleeping 20 minutes prior to arrival with chest pain described as heavy pressure with discomfort into both arms at a pain rate of 8 out of 10. He denied shortness of breath or nausea and vomiting. By 2:14, the vital signs were obtained. They got 160/100, heart rate of 90, SpO2 of 98%. Respirations were 18. A 12-lead EKG obtained showing borderline elevation. They gave him aspirin, 324 milligrams, PO, 18 gauge IV was established. They gave him 1 nitro, administering sublingual with improvement in pain and blood pressure. It's a little vague on times, but from 2:18 to 2:26, patient now showing significant changes on the 12 lead, most significant showing elevation in leads 3 and AVF with reciprocal depression in leads 1 and AVL. The stimulant was called via IHERN. As it was a suspected MI and changes occurred after administering that first dose of nitro, no further nitro administered. Patient was continuously monitored en route for duration of the transport. Well, did I just go completely away? Oh, there we go. By 2:26, full report was given to RN and physician upon arrival. Patient had no belongings in possession of EMS crew. By 2:32, ED physician found EKGs from EMS concerning for STEMI and somewhat changed from previous. So a call was given to the cardiologist that was already in the cath lab. Recommendation from this cardiologist to speak to the patient's own cardiologist who recommended activating the cath lab. They saw that the patient had a really large history of heart problems and had a CABG in the past. 3:26, patient arrived in the cath lab procedure room. By 4:28, wire across the target lesion. 4:33, a balloon was deployed. And by 4:41, a drug-eluting stent was advanced to the target lesion. I thought I'd go ahead and show the procedure was complicated by technical difficulty, which required extra time for crossing the lesion in the right coronary artery. 3 different guide wires had to be utilized. Catheter placement had to be adjusted, and the patient had multiple lesions in the RCA and previous bypass grafts, which required prolonged time to assess. However, the patient's condition was stable and he had a satisfactory end result with successful stenting of several 85 to 95% blocked arteries. I think there were about 3 or 4 of them. So the door to balloon time in this was 106 minutes. The reason I shared this one is because the doctors make a point to put that in their report. If we run over, we need to know why it happened. So it's not related to anything we did in the run or anything we did in the ER incorrectly. It was based on the fact that the patient just had a really hard area to get into because of previous scarring and previous CABGs. Moving right along to our summary of door to balloon times, we still continue to be at 100% from January to July of 2020. And so we're doing pretty good. Thank you for everything you guys do.
Thanks, Brenda. Up next is going to be Jackie doing their trauma report.
Okay, so we're going to go over a couple of runs. It's a little different because usually I like for you guys to interact and you're not here. So I pulled these runs not because of the EMS pieces, but because I wanted you to think about a few things. So the first one I pulled is the gunshot wound to the head. So EMS is dispatched. You know you're going on a gunshot wound. 911 call comes in about 06:20 in the morning. Dispatch sends you out at 6:21, en route 6:23, on scene 6:25, so it's a close to the squad. Left scene at 6:38 and arrives here in the ER at 6:42 in the morning. So shift change for both of us, almost, not quite. So 911 call to getting on scene was 7 minutes. On scene about 13 minutes. I do know this was an upstairs apartment. Had to get a little creative in getting to the person. So 911 call to arrival in ED was 21 minutes, so excellent times. So the patient presented prone on the front steps of the residence, fire rescue at his side, and obviously it's a big chaos. He had an obvious penetrating trauma to his right frontal, posterior left occipital and parietal areas. He did have tissue herniating from the wounds. He had snoring respirations of 10, and there was no other injuries noted. So in the assessment, the medic notes that he's unresponsive. His skin is cold, he's cyanotic, he's diaphoretic, his right pupil's dilated. He does still have pulses in the extremities, which if you remember from Shock 101, your body shuts down from the outside in, so the extremities still have pulses. I don't know that they were great pulses, but he did still have pulses in the extremities. So the first set of vitals, he had a pressure of 130/84. His heart rate is 48. This is a young guy. Respirations are 10. SATs are 86. Of course, Glasgow's down to 3. So they reassess him at 637. Heart rate's still running around 52. Now he's being bagged, so his SATs come up, and end-tidal CO2 is 41. Put him in a C-collar, put him on a longboard, and get him out of there. 2 IVs, 18 gauge, 16 gauge, right and left ACs. They suction him, they intubate him with a 7.0, successful with RSI, so he is intubated when he rolls in the door for us. We call it a level 1 because you gave us the info and we knew to do that. So he arrives intubated with a heart rate in the 40s. So on arrival here, he's got a pressure of 156/83. Heart rate was in the 40s, but we did get it up to 79 at one point. He is still being bagged, and he's 100% because he's tubed. So the ER doc notes that he has a gunshot wound to the right frontal scalp with an exit wound on the left posterior scalp, which we know that you're not supposed to call it an exit wound. He has gross bleeding, his pupils are pinpoint and fixed, and he has coarse breath sounds. So obviously this guy's not doing well. Trauma surgeons at bedside, actually there were 2. They do a fast exam, which is negative, so there's no blood in his belly. We activated massive transfusion protocol, and I forgot to look and see what the total number of units was he got, but it was 6 or 8, I think. We bring neurosurgery, we call neurosurgery, who says, no, this guy needs to go to IU. And IU does accept the transfer, and we actually airlift him out of there. So we contact Lifeline at 7:15 in the morning. They agree to take him. And at 7:21, the trauma surgeon noted that his pupils were equal. He was intubated in the field, talks about the wounds, frontal right, exit toward the left. And he was actually hemodynamically stable, allegedly self-inflicted, which we later found out that it definitely was. And at this point, we didn't know who he was, although that became an issue later. So at 7:25, we actually call Indiana donor. We call IOPO. So anytime a Glasgow drops to 5 or less, we automatically call, regardless of what the outcome's going to be. At 7:41, Lifeline showed up at the bedside. They give him mannitol and antibiotics. At 8:05, they left Union Hospital. And at 8:44, he arrived at IU Methodist. So really good times. Methodist notes that from his past medical history, because we didn't know who he was when we had him, he had a history of ADD, a heart murmur, and he had a fractured clavicle. He had also had a right craniotomy because he had a car crash because he hit a tree going 100 miles an hour. So they admit him to trauma ICU. They have a lot of trouble contacting his family. He's very estranged from everybody. Mom says she hadn't seen him in months once they finally get a hold of her. She really struggles to make decisions because she wasn't sure what he would have wanted. They hadn't talked. It was just a bad situation all the way around. The IU neurosurgeon notes that he had had a craniotomy, post-traumatic brain injury in 2013, so 7 years ago. He had a subdural and a subarachnoid over both cerebral hemispheres. He had a herniation, so not a good prognosis for this guy. He went from IU Methodist ER to OR. He had an emergency decompressive craniotomy, so they had to get that pressure out of his head. His ICP was 40 to 60. Normal is 5 to 15. He does make it through surgery. They transfer him to neurocritical care post-op. So at 12:33, he starts to deteriorate. They call his mom again. She chooses comfort measures. And at 12:50, he codes and died. The social worker noted that PD had told them that he actually had a stolen gun. He had actually shot other people. Then he turned the gun on himself. So it was just a bad situation all the way around. So you're not here to talk about opportunities, which actually there weren't a lot. I thought you guys did a fantastic job. But what I want you to take away from this is some research that says people with a history of traumatic brain injury have lots of mental illness. And we probably brush that off way more than we should. We get people in here who come in here all the time. You guys get them all the time. And they become almost a nuisance, it seems, because they're here for the mental illnesses. But if you trace back, you can usually connect it to a traumatic brain injury. So people with TBIs have major depressive disorders, very, very common. They have poor social function. This guy was the epitome of poor social function. They have higher levels of dissatisfaction at work. He hadn't worked for years. Unemployment, very consistent. Low socioeconomic status. The address alone told you guys that. Less education. Lack of close personal relationships. This was a domestic situation gone bad. His mom wasn't close to him. More frequent alcohol-related problems. Symptoms of mania and OCD and PTSD, which he probably had many of those. So there's the references for the study. So we can't discuss this. So basically, I just want you to remember that mental illness, mental health, those types of things can a lot of times be connected to your traumatic brain injuries. And scene safety is another thing I wanted to remind you guys of. I'm sure you felt like the scene was safe, but nobody documented that the scene was safe. And this guy had shot 2 other people and himself. So please, please, please remember that you're number 1. So, okay. The other one is a farming accident, and had we been sitting in the room, Dr. Mark Lynch was going to come in and talk to you about farming safety. So let's talk about the run, and then I'll give you the generic version because I haven't been on a farm since I was 10. So this is a 28-year-old male that got his arm caught in a grain auger. Calls 911 at 8:35 in the morning, dispatched at 8:41, so this one's a little more rural. On scene at 8:50, at the patient at 8:51, left scene at 9:15, and at Union at 9:51. So it's actually good times considering where they were at. Patient was still inside the grain bin. He was alert and oriented ×4. He said he had pain in his right arm and his hand, and he does have an obvious deformity to it when they get there, but it's not bleeding. So he said he was holding on to a rope that controls the filling and flow of beans, and if you know anything about farming, what they do is they use that rope to make sure that the beans don't get clogged up in the auger. And so that rope goes back and forth across. Not supposed to. It's a bad habit. Obviously, it was a really bad habit for him. So it grabs the rope, pulls it into the auger, and when it does, it pulls his arm in with it. The auger stalled because now they're way better than they were when I remember them. So somebody hit the shutoff, put it in reverse, allows him to get his arm out. He was in the auger for about 10 seconds, they say, so it was good safety measures in place there. He experienced a brief syncopal episode after he was out of the auger. He said it was from excessive pain. Maybe, I don't know. Told him that the pain was 7 out of 10. They do note that he's not covered in beans and he was lying on top of them, so that tells them that he didn't get sucked down into the vortex of the elevator. EMS notes that it's safe to go into the bin to assess and treat him while still in the grain bin, but they don't tell us how they concluded that or who told them that was okay. They were able to get in there and splint his arm, got an IV established, gave him some Zofran and Dilaudid while they waited for rescue. So I don't know your protocols, but I would have thought rescue maybe should have been dispatched when the ambulance was because you had a guy caught in a grain auger. So rescue was called to remove him from the bin to the ambulance. So in the assessment, you note that he didn't fall. There's no head injury, no C-spine or lower spinal injury. It did require a Stokes basket to get him out of the bin, and that was why they had a long scene time. So excellent there. You told me why you had to be on scene for a long time. So there's no trauma alert by EMS or ED. So I think we both missed the boat on that one. This guy fell into a grain auger, actually got sucked into a grain auger. He's relatively stable, but he is young and he is healthy. So he's 135 over 84, 66, respirations are 18, 97% on room air. He has a compound fracture with foreign body, so he goes straight to OR from ER. He gets 24 hours of antibiotics and then he goes home on day 2. So hopefully you can see this. There's his arm. You can kind of see the fracture down under where the Coban's at. There's another view. So he actually does very, very well. He goes to ER or goes to OR. Yep, right there under the bottom. Yeah, so it could have been a whole lot worse than it was. So what I want you to take away from here is the safety, the farm safety. Farming accidents are huge. They're very, very dangerous. We know that. And I think back a few of the things that we did as kids and think that I'm just shocked that we are all still alive and talking. You want to make sure everybody's clear before operating or moving the machinery. Keep your hands, feet, hair, clothes, ropes away from moving parts. A lot of times you'll see loss of limb, you'll see cut and fractures, electrocutions, deaths. I think it was last year, a kid died in a grain elevator up in Parker County. Most auger accidents are operator caused. So here's a few notes on OSHA. I'll just breeze through those. You guys can read them later. Always avoid getting in the bin if at all possible. If you do have to go in, make sure it's turned off, locked out, blocked off. Use a harness, anchor yourself, because as a rescuer, you can get sucked down into the grain as well. Don't ever walk on it. Don't ever enter without having some kind of rescue equipment or trained people. And there are people who take classes to do that. And there are some references for that as well. So, all right. And he stepped out on you, didn't he?
Thanks, Jackie. Hey, Dr. Vishwal is going to speak next. He actually stepped out. I got a phone call. I do want to bring up, though, something for everyone. That the run that Jackie just talked about, the guy with the open fracture, would have been a perfect example to be able to use our new antibiotic protocol. I don't know when this run was, and I don't think it was probably.
Protocols were in effect, but they did not do it. We had one recently that was done, but that one didn't.
Okay, so just remember, medics, that is one good step, because if we can continue to do that, then here at the hospital and at regional, they will be 100% on the antibiotic side of when they're doing their presentations to trauma committees and everything else. They'll know that that's not an issue for them. They won't miss a time frame. Plus, it's better for the patient. So don't forget, if you have an open fracture, any open fracture, that's what that's supposed to be used for. So up next, Dr. Vishwal is going to speak about acute strokes and the COVID-19. So thank you.
Thanks, Barry. Good morning, everyone. I just had this talk on acute stroke and COVID-19 in the recent CME. I wanted to share what has been going on with this COVID-19 pandemic, and then since you guys are all in the main front runners, so what changes we need to adapt, and then how it will impact our stroke management. At any point of time, if you have any questions, please feel free to ask me the questions. So I'll briefly talk about how the evolution of acute stroke treatment and IV TPA with door to needle time, and you guys play a major role in this one, and we'll talk about why it is so important and how we have made it successful. So as you can see in this slide, for every stroke, there is 1.2 billion neurons lost, and about 8.3 trillion synapses are lost. And then if you can see, it also shows for every hour, every minute, and every second, there are so many neurons and synapses and myelinated fibers lost. But what important is, if you see at the last column, for every hour in a stroke patient, their accelerated aging is by 3.6 years. And for every minute, it's 3.1 week, they get aged. And for every second, they're getting aged by 8.7 hours. So this is very important in the field, like how soon the patient comes to the ER, and then how soon we assess the patient and we do the recanalization treatment, either with TPA or with the thrombectomy. If you want to know, this is just a picture showing the neurons and then the synapses. So as I said, time is essence, and then American Heart Association and Stroke Association have launched target stroke initiatives. Phase 1 was goal of less than 60 minutes for at least 50%, and phase 2 goal of less than 60 minutes for at least 75% patients. And now we are moving forward with door to needle time of less than 30 minutes. As soon as the patient hits the ER, our time starts. So why is it so important? Because there have been some studies which showed that, the sooner the door to needle time, and then 1 year mortality and readmission patients. So you can see, there was higher all-cause mortality of 35% versus 30.8 in patients who had longer than 45 minutes. And there were also higher all-cause readmissions in patients who had longer than 45 minutes. When compared to the 60 minutes, you can see that it was 35.8 and then 41.3, significantly higher.
By the way, you're listening too. You're watching too.
Okay.
Eric asked, so. Yes, so we both get credit.
Yes, if we were both watching.
Uh-huh.
Okay.
He says, Morgan watching? Yes.
Is there anyone asking question, or can you guys mute?
You. They hear you.
Yeah, somebody.
Hey, I don't know who's talking on there, but we can hear you talk. Please mute yourself until the end.
Thank you.
So if you can see, this study was a retrospective analysis done from 2008 to 2017. You can see that when there is the door to needle time has been significantly improved. It was 26.4% for 60 minutes in 2008, and it improved to 66.2 in 2017. And for less than 45 minutes, it was 10.7, and now it is 40.5 in 2017. And we are moving towards 30 minutes. So there have been significant association. The sooner we do the treatment, the better is the outcome. Well, the reason why I bring this up is that all this being impacted by COVID-19. Because what happening is with the COVID-19 is, it has been every step in the acute stroke management is getting delayed. And some of the things that we need to talk about is the protected code stroke. So when you're in the field and when you go and first see a patient, we don't know when a patient has a stroke, whether they have been exposed to the COVID or whether they're having any symptoms of COVID. So if you can see this, I think we may have to probably enlarge the slide, but some of the factors, the limiting factors are like, patient may not have ability to speak. So he cannot give you the history, whether patient has any history of close contact with the infectious person or whether patient is having any symptoms. So it becomes difficult. So this was a consensus from the stroke consortium, which included 18 countries, and they said they have come up with a plan, like, on pre-notification. So you may have to, in the protected code stroke, you have to ask few questions. Is the patient exhibiting any infectious symptoms, like fever, cough, chest pain, dyspnea, headache, myalgias, or is their patient had any close contact with infectious symptoms, or is patient has been having any travel history? If they're all positive, then we have to go with the protected code stroke. Then on the history and exam, if there is any patient has any infection control screen done, if there is any unclear history because patient not able to communicate, majority of the stroke patients will have aphasias, or they may have decreased level of consciousness or altered mental status, or if there is any suggestion of non-stroke diagnosis, because with altered mental status, they can either have a stroke or they can be having other infectious process. So what does the protected code stroke involve is mainly using the personal protective equipment and placing the mask on the patient. So whenever you have any doubt that patient may have been exposed, or if he is not giving any history, so assuming that patient may have had exposure, and following the protected code stroke will save all the healthcare workers and the EMS people. So use droplet or contact PPE, which would be a full sleeve gown, surgical mask, eye protection, and gloves. Is there any association, aerosolization, like oropharyngeal suctioning, intubation involved? If it is there, then we may have to use the airborne or droplet precautions. Always place a surgical mask on the non-intubated patient. And if the patient is obtunded and if he's needing high FiO2 or CPAP, then have to consider early intubation. So I've been in discussion with Barry about if we can probably implement this protected code stroke going forward, since we are in the high COVID-19 pandemic. So we'll have to come up with some plans. So when the so that's on the pre-notification screening is done, and then you guys will have the questionnaires, and then assume if the patient has been exposed or if he has had any infectious symptoms. So they will be, you follow the PPEs, and the patient will be having the mask on presentation. So when they come to the ER, inside the room, there will be one MD, one RN, and then the patient will be masked on arrival if they're not intubated. And outside the room, there will be an MD and a safety lead who will make sure that they're all following the safety precautions. So when you are doing this, we are all having delays in the acute stroke management, but at least we have to make sure that we are all protected. So this is one of the case that we had in the month of March, and just briefly run over. A 63-year-old male came with acute left-sided weakness and dysarthria. So everything was kind of like straightforward picture of a stroke. His NS stroke scale was 6, CT head was normal, MRI brain showed right MCA infarct. Patient was outside the IV TPA. We admitted him in the stroke unit. He was started on aspirin Plavix, and 48 hours later, he was discharged to inpatient rehab. So until then, he had no pulmonary symptoms. While in the rehab, he developed acute shortness of breath. There was no reason for him to develop shortness of breath. And he was requiring 4 to 6 liters of oxygen. So we obtained a stat CT chest which showed ground glass opacities bilaterally, and the radiologist called, hey, this is very typical of a COVID-19 pneumonia. So we did the PCR for coronavirus at that point of time. It was in the March. It came back negative, but we treated him as a positive or suspected COVID. But these things can happen to any patient in the field, like, they may call for the strokes, and we are more focused on the stroke management and we forget about the other aspects. So they may have had an exposure, they may be asymptomatic. So it's always better to have the protected code stroke protection with the PPE and the mask before we proceed forward. So these are some of the few excerpts from the studies that have been done since March. So they found that cryptogenic stroke was more common in COVID-19 patients. It was about 65.6, 34.4 had embolic stroke. And what was interesting is that they found elevated D-dimer and CRP in all these patients, indicating high inflammatory state. They all had some abnormal coagulation cascade, and mortality rate was higher among the COVID-19 patients, which was 63.6%. So there have been some hypotheses why these patients with COVID-19 are at high risk of stroke. One, because they're in a prothrombotic state, they have changes in their lipid metabolism, their platelet aggregation is increased, there is alteration in endothelial function, and they can have plaque instability and rupture, which all put them at very high risk of stroke. There have been several studies which are done, like in an antecedent respiratory infection, put them at short-term risk of acute stroke, and COVID-19 is also a respiratory infection. The SARS-CoV-2, which we had back in 2000, was a, SARS-CoV-1 in 2000. Similar to SARS-CoV-2, what we have right now is the 7th known variant of the coronavirus. CoV-2 is genetically similar to SARS-CoV-1. SARS-CoV-1 in 2003 affected about 8,000 patients, and they had fewer neurological manifestations and mostly were peripheral neuropathy and encephalitis. Whereas SARS-CoV-2 also affects the neurological system and appears to be neurotropic, and its manifestation of stroke is related to all the coagulation cascade that we discussed. It binds to ACE enzyme 2 receptor, which leads to cytokine storm and ultimately leading to a hypercoagulable state. Critically ill patients have showed elevated D-dimer levels and also increase in the platelets. Mouse models showed selective blocking of cytokine leads to reduction in infarction volume and improved survival, indirectly suggesting that they're at risk of stroke. This is another article which has, this is a very good article. I'll talk to you about this. What it suggests is that COVID-19 is an independent risk factor for acute stroke. So this was a retrospective case control study from March 16 to April 2020 and was done in 6 hospitals in New York City. There were 41 cases and 82 controls. Inclusion criteria were stroke alert, CT head, or the other imaging modalities in the COVID-19 patients. There were total 139 patients, 123 satisfied criteria. Stroke was confirmed by CT or MRI. And you can see the mean age of the cases was 65.5 plus or minus 15.3, and controls was 68.8. 46.3% of patients with acute ischemic stroke had COVID-19 infection when compared to 18.3% of controls. There was another study which was done in UK, which was only a case series of 6 patients. 3 had stroke in multiple territories. 2 patients had recurrent stroke in spite of being therapeutic anticoagulation. 2 patients had concurrent venous thromboembolism, and 5 out of 6 had positive lupus anticoagulant. So what they found was medium titer for anticardiolipin and other antibodies were positive. So what they suggest is screening for antiphospholipid might be reasonable in patients with COVID-19 associated with ischemic stroke. These are the other few studies that Mao et al. Showed 5.7% had CVA, and these are all the Chinese studies. Li Wei et al. Also found that 5%. The NYU study in the beginning found only 0.9% incidence, but the other study that I mentioned had a higher incidence. So this was from the international panel, and this was also a single center study of 221 hospitalized patients. 5% had acute stroke, and mean age was 72 years, and majority of them had hepatic and renal dysfunction. And there was a possibility that acute stroke patients may have undiagnosed COVID-19 because appropriate screening was not possible, because patient was not able to give any history because of the stroke-related deficits like aphasias, and patients with COVID-19 were in prodromal period, and they might be an asymptomatic carriers, and neurologic deficits seen in the early period infection prompting a stroke evaluation. So this is a proposed workflow. Patient has an acute stroke. So on the field, you'll ask the questionnaire whether it may be a confirmed or it may be a suspected or asymptomatic. Then we go with early identification and separation of confirmed and suspected COVID patients. And they'll be placed on contact and droplet nuclear precautions, or we do sometimes telestroke to prevent the exposure. Next is identifying other organ system involvement, because they're going to have coagulation profile being altered, platelet count may be altered, and they're going to have some abnormal renal and hepatic functions. Then they will proceed with the same like CT scan and MR, CT perfusion, but with the protected code stroke, they'll be having using the PPAs. And IV thrombolysis in selected patients, we may have to consider a reduction in expected benefit because of the COVID-19 infection. What happens is they will have abnormal renal and hepatic function, which impairs the TPA excretion or metabolism and may put them at higher risk of bleeding. So there have been significant impact of this pandemic on acute stroke, particularly reallocation of the neurology and stroke beds and redeployment of the stroke patients, and endovascular treatments have been either reduced or stopped. Administering IV TPA is under threat because there have been increasing in door to needle time following all the precautionary measures. Though we cannot confirm any causal relationship, but there is definitely a significant association. Traditional stroke risk factors were present in majority of the patients with stroke, and they have a pre-thrombotic state which accelerated the stroke pathogenesis. And still, timely assessment and hyperacute treatment is the key to minimize stroke mortality and morbidity, but with definitely precautionary measures need to be taken. This is about the telehealth, we have been using to prevent the, minimize the exposure. And these are the risk stratification of the patients. There may be either low risk, intermediate risk, or high risk, depending upon the symptoms and then their travel history and their exposure history. PPEs, all the standard precautions, all patients, regardless of the risk, must wear a disposable surgical mask, disposable surgical cap, mask, and uniform disposable gloves. Contact and droplet precautions will include the same with disposable medical protective uniform and goggles, or the protection to the eyes. The airborne precaution will include all these with water resistant medical protective uniform and full face protective devices. IV TPA remains gold standard, and we still need to evaluate for the large vessel occlusion and dual antiplatelet therapy and anticoagulation. So regarding IV TPA, we have known that like the infectious stroke, infective endocarditis, we don't do the TPA, but there is no septic emboli in COVID-19, and there is an association, but not a causal relationship. So we still consider them for IV TPA, but we have to be careful because it goes through hepatic clearance. People may have hepatic dysfunction. They may be at high risk of ICH. Not much changes with thrombectomy, but however, you need to have a stringent policy to select the patients who require the thrombectomies. And new challenges do exist in triaging protocols for facilitating rapid transfers from ED to angiographic suite. These are some of the trials which also showed that dual antiplatelet therapy in the early phase, like within 24 hours of symptoms, reduce the risk of non-fatal ischemic stroke, and also decrease the moderate severe functional disability. So we use aspirin and Plavix for 3 weeks, and then we stop one of them. And this is about a flow diagram in choosing aspirin and Plavix. All right. Any questions?
Thank you, Dr. Vishwal. Much appreciated. Thank you so much. Hey guys, I'm going to go ahead and I want to talk to you guys a little bit about some things that been doing a lot of run reviews lately, and it's been very, very good. Some great documentation, some great treatment modalities, some decisions being made in the field that are awesome. Liking the way that you guys are protecting yourselves out there and protecting the patients and protecting the people when you come into the ERs. That is much appreciated from me as an EMS manager, coordinator, and as an ER as a whole, Union Hospital. So I wanted to say thank you for that. Be sure, I'm looking at some of the participants, be sure and get a list to your supervisor, EMS chief, director, owner, whoever you can do to let them know that you were on the call today, and I will get everyone's name on a sign-in list so you'll get credit for today's audit review. If there's no questions, I don't see anything coming up on anything, so I would say thank you and have a great day. Be safe out there, guys.